In this video, you will learn about common pancreatitis complications and how they appear on ultrasound. Use the forward arrow to navigate to the next slide. If you are using PowerPoint to view this presentation, make sure to open it in the slideshow mode. As you are navigating through the slides, you will see a pancreas icon. Click on it to hear more about the subject. YouTube users, the video will automatically play all sounds in key-link terms. The first pancreatitis complication that we will cover is fluid collections. So this is going to be one of the first things to show up, and we see it most commonly with severe acute pancreatitis. And what's going to happen is fluid is going to leak out of the pancreas, and what we'll see then is peripancreatic fluid collections. Most commonly we see these in the lesser sac. That's the area between the pancreas and the stomach. And the lesser sac does connect to the greater sac through that foramen of Winslow, so sometimes we can see it in other spaces in the abdomen as well. Typically, the fluid collections are going to appear within 4 weeks of the initial onset of the pancreatitis, so this is going to be an early finding. And then as far as treatment goes, they can reabsorb if everything starts to heal up and take care of itself. If not, the patient might need a drain, they might need surgery, or we'll see that fluid collection turn into something else, and we'll cover those in a minute here. Now, what fluid collections look like on ultrasound can vary from patient to patient. We can see anechoic fluid, which means that it's just simple fluid leaking from the pancreas, or we might see some echogenic fluid with loculations through it, which usually represents some sort of blood in the fluid. We might see some more solid components in the fluid as well. And when we have those solid components, it gets a little bit trickier to see because that can blend in pretty easily with the bowel. But with fluid collections, it's very important that we are looking all the way around the pancreas, especially in between the pancreas tail and the stomach. And if we see fluid there, we want to make sure that we check out the rest of the spaces in the body that fluid likes to collect. When you think pancreatitis, one of your first thoughts should be a pseudocyst. The two just really go together. So we want to make sure that we understand what pseudocysts are and how to identify them on ultrasound. Once fluid has leaked out of the pancreas, the next process that it goes through is through kind of a maturation. And when that fluid collection starts to mature, the body is going to start to try to wall it off. And that is the creation of the pseudocyst. So we typically see pseudocysts appear a little bit after those fluid collections start to appear. And we always see them with pancreatitis because it is due to the inflammatory process of the pancreas being inflamed, and then all of that digestive enzymes kind of leaking out, and then the body starting to digest itself and not liking that, so then it tries to wall it off, and that's where we get this pseudocyst. We also see it in the setting of necrosis, trauma, and hemorrhage from the pancreas, and they are typically filled with those digestive enzymes, typically amylase. Because these are changes to fluid collections, it makes sense then that pseudocysts like to pop up where fluid collections originally are. So we do see them quite commonly in the lesser sac And then we also tend to see them in the anterior pararenal space. Again, they can be anywhere within the body that the fluid can leak into, but those are the two more common spaces. When a patient has pancreatitis, we really want to make sure that we are checking for those pseudocysts because they need to be treated. The problem is that if those pseudocysts rupture, the mortality of the patient goes up to 50%. So we want to really make sure that we are finding them because there is a high risk that they could die if that pseudocysts were to rupture. Typically, they are monitored and then a drain is placed to reduce the fluid that is in there. Now, with the pseudocyst, there are complications that can arise, and that's because the pseudocyst is filled with some of those digestive juices, so it's going to kind of start to eat away at the tissues that fluid is in contact with. So what we tend to see with pseudocysts is possible aneurysms because it's weakening the walls of the blood vessels that it might be in contact with. It might start to kind of eat away at the intestines, so we'll see bleeds within the gastrointestinal tract, and we might see some ascites in the abdomen, and that's especially with rupture of the pseudocyst. Just like fluid collection, pseudocysts can come in multiple variations. The biggest thing is that there will be a well-defined thick echogenic wall surrounding either anechoic fluid or fluid with some internal debris. And a big thing when you see this fluid collection, make sure you're also taking a picture of the stomach. They're going to have very similar appearances, or you might miss the pseudocyst thinking it's the stomach, or the other way around, you might diagnose the stomach as a pseudocyst. So make sure that you are looking for motion within that stomach, looking for the rugae of the stomach wall, and that should help you to differentiate the two. So when we think pancreatitis, we want to definitely think about pseudocysts. And for how many people are diagnosed with pancreatitis or suspected pancreatitis, these pseudocysts, I wouldn't say are super common because I actually just had my first experience with the pseudocyst not that long ago. And it was on a little girl. She had known pancreatitis. She had been in the ICU for it. And when I was up there scanning, her pancreas was giant. It was huge and it was hyperechoic, could see it beautifully. And right off the tail was this little fluid collection. It was well defined, kind of anechoic with some like little specks of debris within it. And that was her pseudocyst. And it does definitely look a lot like a fluid-filled stomach. And the more that you see stomachs with liquid in them, you'll kind of understand what those look like and how the stomach swirls all that around. So you'll be able to tell them apart, but it does look very similar. But the little girl also had some thrombus in her portosplenic confluence. And so that was interesting to see as well. But we really were just monitoring her every day, seeing how this pseudocyst was changing. Necrotic collections are another complication of pancreatitis, and that is because, again, we're dealing with fluids that are leaking from the pancreas that can digest biological material, and we're made of biological material, so that makes sense that it's kind of starting to eat itself. And if we were to kind of eat through blood vessels or start to eat through some tissue, that tissue starts to lose its viability and it's going to start to die off. So that's the necrosis part of it. And we can see that within the pancreas or outside of the pancreas. So we can have intrapancreatic necrotic collections or extrapancreatic necrotic collections. It just depends on where that digestive enzyme was hanging out and what it's kind of eating away at. On ultrasound, these collections are going to be very well defined. They're going to kind of be another form of what a pseudocyst looks like. So they're going to have nice, well-defined, thick walls, but inside it, the contents are going to look very different. We're going to have kind of lobulations through there. There's going to be liquid and solid components, very heterogeneous appearance. And that's because all of that tissue is starting to liquefy or kind of slough off. It just is going to look like a really gross mass within the fluid that we're seeing. Again, this is probably, it is well seen by ultrasound if we can see the area that is necrotic. We won't necessarily know that it's necrotic, we'll just know that it's kind of a junky looking mass. CT is actually very good at seeing necrotic areas. Again, CT is going to be a very good complement to ultrasound to identify some pancreatic changes. So we talked about one of the complications of having a pseudocyst is that it might rupture. And when it does rupture, this is what creates pancreatic ascites. So now we have that pseudocyst with all the amylase, all the junk in it. It ruptures. That is going to flow out of the lesser sac through the foramen of Winslow and then get into the greater sac. So we're going to see pancreatic ascites in more spaces within the body. When we do see this, it is typically following the confirmation of a pseudocyst, and then maybe the patient has acute pain. We go back in, no longer can see that pseudocyst, but now we're seeing complex fluid throughout the body. This definitely will be confirmed through lab tests once that fluid is drained out of there, because they have to get it out of there. It's not good if it is sitting in the abdomen, but they got to get it out of there. They're going to test it for the presence of amylase and protein. Another complication of pancreatitis is the phlegmonous pancreatitis. And phlegmonous pancreatitis is going to be probably a little bit harder to diagnose by ultrasound because it is a really ill-defined mass around the pancreas. And it might just look like something's kind of wrong through there, but you might not be able to put your finger on exactly what it is. So the phlegmonous part of it is that there is this inflammatory process that's happening, and we have layers to our fascia, and the phlegmonous tends to be in between those layers. So you'll kind of see these striations or these kind of layering effect of the phlegmon. And typically the phlegmon is going to have a little bit of necrosis going along with it and probably some pus within it as well. You'll hear the term fat stranding quite often. That kind of goes along with the phlegmonous pancreatitis, and that's just really echogenic fat that kind of looks like it's in lines, linear lines. We'll see it with pancreatitis. We'll see it quite often with appendix as well. Anything that's kind of inflamed can create these phlegmons that sit around it. On ultrasound, again, it's going to be a really ill-defined mass. It's just going to kind of look inflamed, kind of junky with those fat stranding lines going around it. The last complication that we'll talk about with pancreatitis is a pancreatic abscess. So whenever we think abscess, we're going to think some sort of raging infection going on there. There's bacteria, they're starting to produce air, they're producing pus. It's going to be kind of this gross collection of inflammation leftovers that are sitting in the abdomen. With pancreatic abscesses, it is concerning because these can be fatal. So we want to make sure that if somebody has been previously diagnosed with necrosis or any sort of phlegmon, that we are really looking for anything abnormal in that abdomen to see if there has been an abscess formation. Now this might be a little tricky because it might kind of look like bowel or might easily be overlooked because of it. But make sure that you are looking for a poorly defined mass. It's going to have kind of these odd thick walls. It's not going to be circular. It's going to be kind of lobulated, kind of irregular walls, but they're going to be thick. And then inside of that, you might see some septations, but it's typically going to be kind of more solid with maybe some fluid spaces in there. We might see some air from the bacteria. So you want to make sure that you're checking the whole abdomen for abscesses. It's not uncommon to get an order like that. Typically, too, look at their history, because typically patients who have had surgery and then subsequently developed pancreatitis, those are the patients that are more likely to develop these pancreatic abscesses.